pleasure to welcome today Piotr Radojewski. It's correct or not?
More or less.
I did it better before. From Bern, Insel Hospital. So he's a director of Translational Imaging Center at Insel Hospital, and he's also engaged scientifically and clinically at Institute for Diagnostic and Interventional Neuroradiology. And he's also an expert in 7 Tesla imaging, and also in transitioning between research project and market ready product. Correct? So I'm really happy to have you here today, and I think you will give a nice talk today about clinical values of 7 Tesla. And so thank you again for coming.
Thank you for having me. It's a pleasure to be here. I know some of you. I'm happy to meet those who I didn't meet before. I'm a clinician at heart. That's why this will be clinically focused. Let's start with a very, very basic observation from the clinical point of view. The machine has been cleared by the FDA and CE in 2017. It's an obvious thing, but I still stress this in my talks because many colleagues, many clinicians don't realize it. They think 7 Tesla is a research thing, so I always want to stress it's CE marked. That means you or I can examine a patient based on clinical indication without the need of including a patient in a clinical trial or a study. So this is basic but important, and we do examine clinical patients in Bern, and quite a lot of them. And our idea of implementing 7 Tesla in the daily routine is to use it as a complementary tool to 1.5 and 3 Tesla. We don't see it as a replacement. We want to meet the unmet clinical needs and fill the void. And we call it internally advanced patient care to say that we don't use it broadly, but just for specific indications and questions. And now with the information that we have, the clinical approval since 2017, it's fair to ask the question, what's actually the body of evidence to support clinical daily use of 7 Tesla? And we did a systematic search together with teams in Geneva, Zurich, and Frank was also involved to answer this question. So we search for comparative evidence, studies reporting on comparison between 7 Tesla and other diagnostic modality. There are tons of papers on 7 Tesla only, but we only identified 83 papers reporting comparative evidence. 7 Tesla versus other modality. And if you look at the indications, that you realize that 7 Tesla is clearly a neuro machine. Because the vast majority of studies report on neuro, minority on MSK, and there are some other indications. The comparator was 3 Tesla in 60% of the studies. 10% use multiple comparators, 10% skip the 3 Tesla and use comparators as well. 5 Tesla, and you can argue there what's really the benefit of this comparison. And the remaining studies included other modalities like PET, angio, and so on. There were no randomized controlled trials, and there were no multi-center trials, which is an interesting insight for us here in Switzerland, because there's an opportunity for us. And because I'm focusing on neuro, and this is the vast majority of clinical applications, I will walk you through the clinical neuroimaging at 7 Tesla. So by number of papers, cerebrovascular indications were the largest group, followed by multiple sclerosis, then epilepsy, and smaller indications like brain tumors, pituitary gland disorders, movement disorders, and a large group of other. Here you can find, for example, forensic indications. For example, the NFL players, if they are suing their teams, association of NFL players recommends to do 7 Tesla. For us, it would be the equivalent of SUVA, doing these kind of scans. If you look at the number of total included patients, then epilepsy is the largest indications, followed by vascular indications. This is an umbrella, and then MS, the top three. I will start with epilepsy because it has the largest, so the best body of evidence, and it's also historically one of the most established indications. We identified 12 comparative studies, most of them focusing on treatment refractory epilepsy with patients regarded as non-lesional when examined with the 3 Tesla scanner. Majority of the studies reported surgery outcomes, which is a very good quality study, and some reported correlation between histopathology and the 7 Tesla. So did it really match our hypothesis on the histopathology? And there is even a consensus on the use of 7 Tesla in epilepsy, and our colleague from Geneva, Serge, was involved in writing this. So we know that we find more lesions when using 7 Tesla, and especially in patients who are considered non-lesional using the standard field strength. We did a quick quality check. We've now examined way over 200 patients with epilepsy in Bern. So what we did is we let do a reading for 2 pairs of neuroradiologists. All pairs experienced who have a dedicated training in 7 Tesla. These were colleagues from abroad, and 2 experienced neuroradiologists without dedicated 7 Tesla training. And what we saw, that it's not only about the pure field strength. See here that those with dedicated training really detect more lesions, and those without experience actually don't benefit so much from the field strength. This was a very interesting observation. We did it for our internal quality control to understand how we teach people and prepare people to read 7 Tesla. And I'll show you a few examples from our daily routine. This is a young girl with a first seizure in 2012. Here you see the standard imaging, 3 Tesla MRI. During the seizure, then a PET scan a few days later, and it was reported as non-lesional. And then several other examinations over 10 years were reported negative. Until we had 7 Tesla scanner, we examined her, and we see a clear lesion in the right frontal lobe and the insula. We see an impaired differentiation between the gray and the white matter, and nicely compared to the contralateral side. You can draw a line with a pencil here, but not here. We postulated focal cortical dysplasia type 2. The patient went into surgery. It was confirmed, and the patient is now seizure-free. Now, if you look back carefully, you can see an asymmetry here. This was the first seizure, so you can see an edema of the cortex. And on the PET, actually, you can see a symmetry. So this is a hypometabolism, suggestive actually of an epileptogenic lesion, but it was seen, but not reported as significant. So it was detected, but reported, okay, this is just noise, this is not real. And this is even a more subtle case, especially interesting in the context of missing 7 Tesla training. People without experience would potentially miss this lesion. This is a very, very subtle abnormality between the gray and white matter. Here, visible on the T2. Again, focal cortical dysplasia type 2. Patient was operated on, as seizure-free. And here you also see our working horses in epilepsy. So the T1 and T2 range, and T2 spin echo 1.5 millimeters. So this is our certain most routinely run sequences in epilepsy. We also run hippocampus dedicated sequences with 0.7 millimeter slice thickness to detect hippocampal sclerosis. And these 2 always belong to epilepsy protocol at our institution. And here you can see a normal architecture of the hippocampus. This is a healthy. You can see the nice duration. And this helps in detecting or confirming, rejecting the hypothesis of hippocampal sclerosis. This is the standard at 3 Tesla. Patient referred to us with the question of hippocampal sclerosis. You have 3 millimeter slice thickness, Do you see one? Yes or no? Do you see the 7 Tesla scan? Maybe some of you can see the symmetry already. So here you see the architecture. The architecture is missing the control arteries. If you look closely, you can see some asymmetry on the 3 Tesla scan, but it's much easier on the 7 Tesla scan. And this is also what we do. We see patients with this ambiguous hypocampal sclerosis. So we are not sure at 3 Tesla. We even run our AI model for detection of hypocampal sclerosis. It's still unclear, and you can usually differentiate them at 7 Tesla. And what we also added quite recently to our protocol is the mapping of neurotransmitters for epilepsy patients. The GABA and glutamate is a whole brain mapping to detect abnormalities or imbalances in excitatory and inhibitory impulses. So this is a quite new development and only available at 7 Tesla. It cannot be done at 3 Tesla at the moment reasonably. And I will talk a bit later about it in more detail. Okay, let's move around our pie chart. The next group by number of patients would be vascular indications, but because this is an umbrella, let's leave it for the end and move further to MS, the third highest number of patients. Here, we found 13 comparative studies, clinical questions were very heterogeneous, mostly focusing on relapsing remitting multiple sclerosis, and the main reported outcomes were lesion count and lesion characteristics. There were no studies reporting on comparison between the image and histopathology, but we have to be fair here. It's way more difficult to provide this in MS than, let's say, in epilepsy, where the patient receives surgery. Anyway, there is sort of an approach to a consensus similar to this one in epilepsy. So we agree that we see more lesions, or the community agrees that we see more cortical lesions especially. But what's still not clear and not worked out yet is how this translates into patient benefit. So we see more, but there is still no consensus how we can translate it into a patient benefit. What we do at Inselspital, we see 2 groups of patients. First one are patients with unclear initial diagnosis. So for example, a myelitis, so lesions in the spine, the myelin, but no lesions on the brain MRI suggesting inborn. These are patients we see at some tests. And then the other group are patients with sort of unclear progression. So a worsening MS patient with no clear correlation on a 3 Tesla scale. So for the initial diagnosis, we mainly search for cortical lesions. And you can see 3 examples here of very subtle cortical lesions, and these tip the diagnosis. So when you go along the McDonald criteria, tell is this an MS or not, these cortical lesions constitute one compartment and can move on the diagnostic scale from negative to positive. And these are usually not visible to Tesla, or sometimes they are visible, people see them, but interpret them as insufficient suppression in the deep sulcus in the flare, so as an artifact. This is the other patient group with unclear progression. There we run SWI and search for paramagnetic rims. It's a heterogeneous topic, but from what we understand so far is that they are associated with pyra progression independent of relapse activity. So the smoldering background progression, they grow, at least a subgroup of them grow over time. They are associated with worse outcomes with increasing brain atrophy. So this is a patient who was being treated at an external institution. He had a long progression, and then he came to us, and it's obvious that every single lesion has a paramagnetic rim, and the patient was then included into clinical trial of proton tyrosine kinase inhibitors, which we will talk in a minute about. Here you see one screen with all 3 markers that we use at 7 Tesla. They can be seen at 3 Tesla, but it's way easier to see them at 70 on the study. So you see the paramagnetic rim. as a diagnostic, and also prognostic marker, maybe even predictive. Then you see the central vein inside as a purely diagnostic marker, now increasingly important after the last revision of McDonald criteria. And you see the outside rim, the hyperintense rim, which is not delineation, but this is edema and axonal damage. The lesion will grow in this direction over time if not treated adequately. And on iron staining, for those who are not familiar with MS, the ring is associated with iron-loaded macrophages, which accumulate around the lesion. And this topic is now becoming interesting with the very recent positive results of the Hercules trial. And there are still phase 3 trials running in the States using environment rim as a prognostic marker for the treatment of kinase inhibitors. So the idea would be that you treat the patient and the rim shrinks, becomes smaller under the treatment, even before you can see a clinical improvement. So you have an early biomarker. Still a hypothesis, but an interesting direction to look at. Again, our internal quality control, we looked at the first 80 MS patients at our institution, and you can see clearly that the majority are this unclear initial diagnosis, and the minority actually this unclear progression. And you see the patients. This is how they arrive at our 7 Tesla center. These are the indications for 7 Tesla. The main message here is heterogeneous. You see different questions. Then we do a 7 Tesla scan and basically binarize them into MS or not MS. And what we did here, we looked what happened with the patients in the future. So often in MS, the only gold standard you have is the time. The time will show what happens to the patient. And when you compare those patients' follow-up with the 7 Tesla outcome, we end up with a sensitivity of approximately 90% and specificity of 78%. So what we compare here is basically my radiological reports versus what happens in 2 years. Which are actually quite nice values, and our MS neurologists are happy to have this supportive tool because this is a support for them. If they have an unclear case, we can run a 7 Tesla and quite clearly tell them if this is an MS or not. Let's move ahead. I grouped the next 2 indications together: brain tumors and pituitary gland disorders. For pituitary gland studies, there is a small but quite robust body of evidence. So we understand that we can search for adenomas and we can do it quite efficiently. For brain tumors, the evidence is very, very heterogeneous and rather weak. There are multiple correlations of different parameters, but very few studies, or almost no studies, comparing 7 Tesla, 3 Tesla, and histopathology, so the gold standard. We use, in Bern, we use 7 Tesla in brain tumors just for 1 indication, and this is preoperative characterization of brain tumors. So the first question when you have a suspicion of a glioma is this an IDH mutated tumor or a wild type? The mutant has a better prognosis, the wild types have worse prognosis, and your neurosurgeon can approach these tumors differently. So for a mutant, you can go aggressive because the patient will have better prognosis, while for the wild type, you can be more conservative, do a debulking because the outcome is bad anyway. And you can know this before the surgery. The routine procedures that use biopsy or surgery, then process the tissue and have the answer anywhere between 1 day and 2 weeks after the surgery. We can do this with a quite good accuracy within 10 minutes per surgery. Because there is a well-established biomarker for MRI, its accumulation of 2HG has been described in the setting of 3 Tesla. So when you have an IDH mutation, a metabolite 2-hydroxybutyrate accumulates in the cell, you can try to measure it. It works at 3 Tesla, but of course with 7 Tesla, we increase the spectral dispersion. We have a much better starting position to measure it. And here you see an example. You see a large tumor in the right frontal lobe, so where the red box is drawn, and the blue box is the healthy side for comparison. This is a whole brain slow EPSI spectroscopy. So you can see the standard information in the slow full window. So you have the information about NAA, creatine choline, and myoinositol, all the information you want to have in a tumor. But on top of that, in the editing difference, we search for 2-hydroxyglutarate at 4.02 ppm. And here you can see actually a peak, meaning the metabolite accumulates. This is a mutated tumor. And this was a grade 2 astrocytoma. And here you have a quite benign looking tumor in the left parietal lobe, again in the red box. And no accumulation at 4.02 ppm, meaning we don't have the metabolite. We postulate a wild type, and this was a grade 4 glioblastoma. The next step on the decision tree is the presence of or absence of one p19q codeletion, which is a marker of oligodendroglioma. So you want to differentiate, is this an astrocytoma or oligodendroglioma? And this biomarker was postulated by the Marianska group in the US, and there were abstracts and papers by Branzoli. They postulate accumulation of cystathionine in the presence of one p19q codeletion. So you see cystathionine, meaning this should be an oligodendroglioma. And what you do here is look for peaks at 2.7 and 3.8 ppm. These are very subtle peaks shown by the arrows here. We do it as well, and here you see an example. Our whole brain slow EPSI spectroscopy. We draw our ROIs afterwards during the analysis. Red tumor, blue no tumor. And here you see both 2-hydroxyglutarate and cystathionine. So this means it's a mutated codeleted tumor, so it must be oligodendroglioma. Now the accuracy for 2Hg at 7 Tesla with our method is above 90%. The accuracy for the standard spectroscopy when you try to do it at 3 Tesla is anywhere between 30 and 70%, depending on what method you use and so on. This is not true for the cystathionine, so this is still way less established. I'm personally still quite skeptical about this biomarker. So I believe strongly in 2Hg. I think there's enough evidence. With cystathionine, we still must accumulate more evidence on this biomarker. Let's move ahead. The next indication would be movement disorders. Here we have, again, small but solid body of evidence with 2 indications for 7 Tesla. Planning of deep brain stimulation with the promise of a little bit better accuracy in placement of your electrodes, and initial diagnosis, which is a very simple binary thing. Looking for the so-called swallow-tail sign with the presence, like you see here, meaning it's a physiological state, the absence, the loss of hypertensity being suggestive of Parkinson's disease. So how you can use 7 Tesla is sort of an equivalent of similarity to the DAT scan. And that's how we're using 7 Tesla. So instead of doing a DAT scan, so a nuclear medicine method, we can consider running 7 Tesla. DAT scan gives you only information of the dopamine transporters, nothing else. Here you have a whole brain MRI, so you can exclude other possible causes. Okay. Now we move to the cerebrovascular diseases, which is an umbrella, quite heterogeneous. You can subdivide it into 4 groups: large vessels, small vessels, aneurysm, and malformations other than aneurysms. There are 14 papers in total, and these studies reported anatomical delineation, lesion detection, lesion count, and diagnostic accuracy. The tools that we use are, you're all very familiar with those, so it's a TOF. I like it because it's nice to depict periphery and small vessels like the perforators. And we use vessel wall imaging. So T1 space before and after contrast application. And here you see an example on the left, no contrast, on the right hand side, image after contrast application. And there is one specific systematic review reporting on vessel wall imaging at 7 Tesla, and the authors found studies on atherosclerosis, aneurysms. They did not find any studies on vasculitis or small vessel disease. However, vasculitis is a very common question at our 7 Tesla centers. We receive many questions to rule out vasculitis. This is the standard at 3 Tesla. So we have the vessel wall imaging at 3 Tesla is well established. However, it's error prone because of slow flow enhancing veins in Bios alpha. There's a risk of producing false positive results. And this is such a case. You see a lot of enhancement, but actually, when you run 7 Tesla post-contrast in the same day, you see it's all not real. It's a missing suppression of the signal. The only thing you can see here is an arteriosclerotic plaque. There is no sign of vasculitis. So it was a false positive case at 3 Tesla. Here, you see a true positive case. You have to look at the left cerebral media artery with the long spiculated enhancement along the vessel. You can see the lumen, which is quite advantage of the 3 Tesla. And this is what happened to the patient 1 month later. She was not compliant with treatment and she presented with worsening symptoms with aphasia. You can see increased inflammation, so more contrast enhancement, and no lumen at all. So there's no blood supply to the left hemisphere. Atherosclerosis is probably the most common indication to run 7 Tesla in vascular context. Here you see work from a collaborator at the University of Iowa, Edgar Samaniego. He works with the concept of a culprit plaque. So this is a patient with stroke in the left basal ganglia. The patient received angio, and the cause of the stroke was not identified. So the stroke was first classified as cryptogenic. And then he does 7 Tesla in the post-acute state, so in an elective setting, and he identified a plaque in the left medial artery and identified as a culprit. So a plaque causing the stroke. However, what's missing here, because they just simply don't have the technical setting, is a comparative evidence. We see this at 7 Tesla, but if we would run 3 Tesla, maybe we would see it again. So this remains unanswered. That's why we have a prospective SNF-funded study on vessel wall imaging and stenosis. The study is still running, so I cannot report any results yet, but you can see at the first glance, this is 3 Tesla standard. Sort of don't know what's going on here, while this image, and believe me, on a proper monitor, it looks even better. You can nicely see what's going on. There's a plaque with just a tiny lumen left. So you can understand the stenosis and the grade of stenosis. Here one more example. A large plaque with tiny lumen left, so you can precisely measure the grade of stenosis. You can identify vulnerable plaques. So this is an ulcerated plaque, a hole in the wall in the right ICA. Here. Or you can even see a thrombus formation inside the vessel. So with 7 Tesla, we move what's possible now at 3 Tesla at the carotid level towards the intracranial regions. The same tools actually apply to small vessel diseases, so small vessels. And here you see a patient with multiple stroke of different age in both hemispheres, with acute ones on the left hemisphere. And we can apply vessel wall imaging as well to those patients. And you can see here inflammation or enhancement suggestive of an inflammation in the left hemisphere along the peripheral arteries, matching the territory of the fresh strokes. And this is also something completely invisible at 3 Tesla, which you can see in the upper row. Aneurysms is another well-established indication, one of the historically very first at 7 Tesla. We in Bern found a niche, a rather niche indication, which we consequently do, and these are small findings, clarifying very small findings. So here in the anterior circulation, you see two spots on the top, but actually only one belongs there. We as radiologists want to be on the safe side, so we postulate an aneurysm there. This means for the patient that there might be an aneurysm or not be one. So you follow up the patient to see what happens. Is there a growth or not? If there's absolutely no growth, it might not be an aneurysm because we are at the risk of generating a false positive finding. An aneurysm can look very much like an infundibulary branch. So infundibulary branch is a normal anatomy. Aneurysm is a pathology which must be observed and maybe treated. But if you run a thick slice over these, it's easy to create a false positive finding. And this was the case here. When you reconstruct the top, you nicely see this infundibulum, the triangle, okay, and here a tiny vessel emerging. And especially anterior circulation is at risk of producing these false positive findings because the anatomy there is complex. And when we look at our internal aneurysm cohort, the most of these false positive findings actually occur in the anterior circulation. And we now run 7 Tesla to clarify this ambiguous case. Because it's always easier to run a 7 Tesla than to, let's say, move the patient to angio, because this is way more invasive. And this is probably my favorite case of aneurysm. This is posterior circulation tip of the basilar artery. And our colleagues postulated an aneurysm here. It's fair to tell it's an aneurysm. So the patient was then followed up for 3 years until we had 7 Tesla scanner. You can see here again a triangle and a vessel emerging at the tip, which is not an aneurysm. It's an infundibulary branch. And this can have an impact of patient's life because each of us reacts differently to diagnosis. Some people don't care. I might have an aneurysm, I live a normal life. Some patients are rather frightened and are paralyzed in the normal life. This was a patient, that's why it's my favorite case. The aneurysms was a patient who really was impacted psychologically by this. And telling him that he never had an aneurysm was a great relief. Okay, let's move ahead down the indications. Arterial venous malformations. This is rather rare, and the same principle applies here than in aneurysm. So we use the SNR to depict very, very small structures. Meaning here, a nidus. So the heart, the center of the arterial venous malformation. And here you see a case of a hemorrhage, 1.5 Tesla SWI, has an encephalic hemorrhage without any cause visible on 1.5 Tesla. Then 3 Tesla was performed with the hope that you can see more. It was reported negative. And then we saw the patient with 7 Tesla. And you can see a pile, a network of small vessels here. This is a pile, AVM, the nidus of an arterial venous malformation which ruptured. If you look back at 3 Tesla, you can recognize it, but it's always easy in retrospect and hard to prospectively tell, okay, there's a nidus. And this has consequences because this nidus can be then irradiated to prevent rebleedings. It's an interesting indication, but it's very rare. I have to say this, maybe 10 a year at least. We looked until now on the TOF on space, but there's of course very important sequence for the understanding of vasculature, CSWI. We use it primarily for diagnosis of cerebral amyloid angiopathy, which means it might be interesting in the context of ARIA-H, should the Alzheimer drugs be approved in the market. So a new avenue opens.
Let's see.
What surprised me while looking at the evidence is that there's actually quite poor body of evidence. The best study that we found is actually 10 years old. In an interesting cohort of patients, they looked at glioma patients who were irradiated and then developed microbleeds as a side effect of the treatment. And there you see more on 7 Tesla than 3 Tesla. But other than that, the evidence is quite poor. And this surprises me because if you look at the images, it's very intuitive that you see more. Here's the same patient with cerebral amyloid angiopathy. You can nicely depict the cortex and the bleeding inside the cortex. They're very typical for cerebral amyloid angiopathy. Or here, even more subtle bleedings. Here's superficial siderosis, typical for CAA. You can see this also at 1.5 Tesla, but you cannot see it's very, very tiny microbleeds inside the cortex, typical of cerebral amyloid angiopathy. We're at the end with the indications now. So summing it up, there is some body of evidence, but it varies strongly from indication to indication. So very, very relatively good evidence for epilepsy, basically no evidence for vasculitis, which we still do in our routine. But before we end, I would like to have a look in the history of medicine. This is a very similar work done 10 years ago, more than 10 years ago, by Joanna Wardlow and her team, comparing 1.5 and 3 Tesla. And what they wrote at the time is that they found no or little evidence of improved diagnosis between 1.5 and 3 Tesla. And there is basically no evidence justifying purchase of 3 Tesla at the time. Now, 10 years later, 3 Tesla is an integral part of our routine, recommended in multiple guidelines for epilepsy, for MS, and so on. So the body of evidence here accumulated over time later. Now the question is, will the same happen for 7 Tesla? We have one change in the landscape, which is the new MDR. This wasn't in place during the comparisons of 1.5 and 3 Tesla. And this MDR creates a stricter environment for us, for MRI imaging in Europe, and making also provide evidence harder. When you look at the idea of the new MDR, the legislator wanted to put something, an environment similar to pharmaceutical environment. So the question is here, can we learn something from the pharma industry? One thing that I've discussed with several of you over time, will the role of vendors in this ecosystem change? And if yes, how? We see this change already happening with the changing of the VIP sequences, for example. So we are at a different environment than people at the time of comparison between 1.5 and 3 Tesla. And I think, and I see this as my task as a medical doctor close to 7 Tesla, is to find the right balance between pushing innovation, but also investing resources into evidence generation. We need to generate the appropriate evidence that it's useful for clinicians and then actually for the patients. Before ending, one last slide. I always stress the importance of ecosystem around the machine. It's very important that we all talk to each other, doctors, physicists, technicians, vendors, and so on. And because I'm in Geneva here, we also create an ecosystem for the 7 Tesla systems in Switzerland. I think it's a great opportunity for multi-center trials, which are completely missing in the field right now. And with this, thank you for your attention, and feel free to write me if you have any questions, and also feel free to visit us in Bern.